Hello and welcome to this video. My name is Dr. Lask. I'm a consultant radiologist and one of the people that run the radiology seminars and this MSK community. We're going to do a roundup of cases every once in a while so that people can, if they don't want to scroll through, they can just watch the video and hopefully learn a few things. Let's have a look at this particular case that was brought up. What we have here is someone who's had a hip replacement. You can see there's a fair bit of artifact located within this region over here. And over here, you've got this sort of really abnormal looking lesion that's extending outwards. And this is the T1 weighted images from what we can see. You've got your fluid sensitive sequence over here, and you can see that there is a bit of increased fluid located within the same lesion. Urinary bladder's got fluid, so is this. So this is definitely some fluid, but this also has a very thick sort of bursa around it with some synovial thickening as well. Now, when you're looking at the position of it, it looks as though it is deep to the iliopsoas tendon or around the iliopsoas tendon, suggesting that this is most likely to be an iliopsoas tendon bursa. Because this is a hip replacement and in the region of the iliopsoas bursa, we're thinking that this could be a second reaction, so a metal on metal reaction, alval, ALVAL. It could also be a pseudotumor. Ultimately, we're probably going to end up needing to take a sample of this to try and understand what exactly is causing this. So that was quite an interesting case from this week. Next case we had was this one where we've got a patient's thigh. So go to full screen and have a look. We can see just there's some fluid signal located within the left rectus femoris muscle. And it does look like the tendon is completely torn. And there's also some retraction of the tendon as well. So this would be in keeping with a very high grade tear. I think if you were to go to the British Athletics classification, this would be like a grade 4 full thickness tear. That's essentially what it is. And there's some retraction there. Looks like they're quite young patients, so may benefit from getting it reattached. Next case, we have looks like we've got the image of an ankle within this region over here. You can see there is an abnormality. So where are we? We're in the lateral aspect of the ankle. This is the medial aspect of the ankle. You got Tom, Dick, and Harry. And then over here is going to be a peroneus brevis and peroneus longus tendon. And here you can see that this is very edematous, and the brevis looks like it's about to split here as you get further down. This is looks like a T1 weighted image, but you can tell this is very edematous and very abnormal. So that's the most likely abnormality there. Right here, we have got quite an interesting case, not something that I was particularly aware of, to be honest with you. And this looks like an accessory muscle, right? So it says it's a peroneus quartus. So the peroneus quartus muscle is like an accessory muscle, and that's what we're seeing here. You can see the sort of fibrous appearance to the muscle, and then you can see the tendons over here. And these are going to be your peroneus brevis and peroneus longus tendons. So this accessory muscle essentially can result in a bit of impingement onto the peroneus tendons and then can end up resulting in a split tear. So quite important to have a look if someone's got lateral ankle pain. Okay, so this next case looks like a video. So we just full screen it and have a look and see what's happening. So yeah, we can see that patella is very laterally placed. There's a bit of chunk patella that's sitting over there as well. Can you see that? So there's a bit of chunk of fractured chondral surface there. It's probably come off the patella, big joint effusion. Quite a young patient. You can see a few growth plates. There's that chunk of patella that's sitting up at the top there. Sagittal views, and we can see, yeah, a bit of patella that's sitting up there, and a very laterally placed patella. So yeah, quite interesting case actually. So with these ones, we can see that the patella is very laterally placed from the trochlear groove. Actually, it's quite easy to see. And it looks as though that this patient is probably predisposed to getting a sort of lateral patella dislocation because that TTTG is going to be quite high. What we need to do is identify where that tibial tendon is and then see how far across this is from the trochlear groove. Maybe we'll do a full lecture on that as well. The medial patella tibial femoral ligament looks actually okay, doesn't it? But this is very abnormally placed and probably end up needing to go on to have surgery. Okay, so this case looks like it is a spinal notch cyst, actually. Let's just have a quick play through. And yeah, you can see that. And interestingly, you can see that there's a bit of increased signal located within that muscle belly over here. And so what you have here is going to be the suprascapular nerve. And then when you've got a cyst like this that's located within that region, it can cause a bit of mass effect onto that area and then result in a bit of atrophy. And you can see there's a definite sort of abnormality with regards to the muscle signal on the fluid sensitive sequence. There's a fair bit of atrophy located there as a result of this. Apparently, a lot of these cysts come as a result of slap tears. I thought this one was coming because of coming from the actual glenoid, like a paralabral cyst. But according to literature, usually it's going to be a slap tear that causes this. So This area looks like we've got a weird looking lesion located within this area over here. We've got the T1 weighted fluid sensitive sequences and the T1 weighted images again, and we can see that there's an increased amount of signal located here, slightly diminished single here. So it looks slightly, yeah, it looks like it could be a bit edematous, ill-defined lesion. Doesn't look like there's any cortical reaction or any cortical displacement or fractures or anything like that. No soft tissue component. The soft tissue is very thin along the side of it as well. So it looks like a bit of an odd lesion actually, doesn't it? This slight fatty component could mean that it's a hemangioma. Alternatively, it could be a developing non-ossifying fibroma. This probably will need a follow-up CT scan and even potentially biopsy to try and really identify what it is. But at this present time, it doesn't look like anything aggressive. Okay, so let's go to this case. So this is quite interesting. Clearly, you've got your fibula here and you've got quite an extensive lesion that is located within this region. Whole load of soft tissue swelling located over that area as well, and a few tiny sort of calcifications located within the soft tissue. So the quiz was an osteosarcoma versus an Ewing sarcoma. So apparently this was a biopsy-proven Ewing sarcoma. The other thing that kind of makes you realize it's probably likely to be an Ewing sarcoma is the fact that there's so much soft tissue swelling and only a few areas of calcifications are located within that region, suggesting that it's more likely to be an Ewing's. This was a very abnormal looking lesion located within the region of the subcutaneous tissues of the left gluteus or sort of subcutaneous tissue of the left buttock. I think it was ended up indeterminate. Would be interested to find out what the follow-up of that one is. Next case was a fractured rib on ultrasound. So yeah, quite difficult to normally see, not something that you'd normally get. Now, we had one of our resident experts tell us a little bit about looking at these. You can find a bit of hematoma. It's also quite important to look at the nerve, whether there's any sort of nerve damage or any sort of nerve impingement when you have a fracture like this on ultrasound. This was a very interesting case because what you can see here is gross thickening of the patellar tendon, lots of edema, it's post-trauma, and you've got this sort of area of calcification that's located within the region of the tibial tuberosity. Now, I wasn't entirely sure what this was, but I thought it could be but apparently this was also a partial avulsion of the patellar tendon as well. So that was quite an interesting case that came. So yeah, this is an interesting case. You've got this sort of lesion that is located within the proximal fibula. It looks well defined, looks like some scalloping of the underlying cortex. I would worry that there could be a potential of getting a fracture. There's no periosteal reaction, no periostitis, no evidence of an inflammation anywhere. And yeah, we had some really interesting discussion here. And one thing that I thought would be quite interesting to look at is that in RNOH, their follow-up is that if the lesion is less than 5 centimeters central with interspersed fat with no scalloping, you can discharge. But this one, you can see has got scalloping. It looks quite big actually, and is not quite central. So in that particular case, you'd do a single 6-month follow-up. And if it's stable, then you end up discharging. So quite interesting, actually. It's definitely worth talking about, mentioning, describing, and then knowing that there are criteria for safe follow-up of this particular patient. This one is someone that came up with me. Person was an IVDU person, so they were basically injecting drugs into their groin and end up getting a really significant abscess. And I think this was the previous scan, and they were doing a lot better post-treatment, actually. So this is multiple collections interspersed between the fascial planes of the adductor muscles and some of the anterior compartment as well. So quite unfortunate situation. This was very interesting. I've never really seen a case like this before, admittedly. This was query plantar fasciitis, and actually the plantar fascia was completely normal, but there was a fair bit of inflammation located within the region of the cuboid. So that's calcaneal cuboid. And it was very focused within that region. I could see this linear sort of signal, low signal thing sitting over here. So I thought it could be like a calcaneal cuboid ligament. And actually that was brought into the potential possibility. Ram has said that, yep, you do get something like this. You get plantar calcaneal cuboid ligaments, particularly it's the short plantar ligaments that is on the dorsal a little bit higher up. Yeah, no repetitive trauma from what I remember. It was just foot pain, query plantar fasciitis, but something to be aware of if that comes along your way. That was this one I thought was really cool. And I just press play here. And honestly, at first I thought it was like one of those bad sushi cases where you get multiple like larvae located within the body, but actually it turned out to be NF1s, and these are all along the sciatic nerves. These are also neurofibromas along the nerves, which is, yeah, really crazy case. This one was a person had a history of mantle cell lymphoma and now's got persistent swelling of the calf, had a DVT scan, no DVT, ended up having this MRI, and you can see this diffuse infiltration of the posterior compartment, isn't it? Really horrible. So most likely going to be underlying malignancy that has gone on there. It's quite a nice case, a bit of bread and butter case, but I think there is. So I usually describe it as a champagne glass like this. If you draw the champagne glass like this, and you can see there is what looks like a bit of a break there, a bit of a fusion there as well. So I would probably go with a supracondylar fracture in this particular situation. This one, yeah, I thought this is quite good because you've got a bit of inflammation there, a little bit different from the osgood flatters. This is going to be Syndig Larsen Johansson, where you've got a bit of inflammation in the proximal patella, and you can see a bit of tendinosis there as well. Now, this was a weird indeterminate lesion that we were concerned about, weren't entirely sure. Small lucent lesion located within the proximal humerus, and the person got a history of prostate cancer. So as you can tell, we're a little bit worried. Looks a bit intermediate signal, a bit of fluidy signal over here, and then it almost felt like there's a vessel coming up underneath there. But I think we've had a comment from resident expert who says most likely a tiny enchondroma. I probably would have gone for a follow-up, but fair enough. Yeah, most likely an enchondroma that is sitting there. This one you can see we're probably what L4, L5 of the lumbar spine, and you've got sort of this indentation there, and some adjacent bone marrow edema. Was worried about discitis, but actually the disc looks very normal, and it's mainly around the sort of indentation here and here. So I'd be more concerned that this would be in keeping with a reactive Schmall's node. Yeah, and I think that is it for the roundup, and I think we're just waiting on a few more comments. So the next video will probably have a roundup of probably around here onwards. So I hope that was useful, and as always, thank you so much for being part of the community, coming in with like positive vibes, positive attitude, and hopefully, yeah, keep asking away, and we can all help each other become better MSK radiologists. And keep your eyes open because we will start doing weekly meetings and hopefully have some proper teaching sessions going through some of the topics that have come up during the week. All right, speak to you guys soon. Bye.